You are closing a laceration on a construction worker's forearm when the power goes out in the emergency department. The man on the table curses. You don't stop stitching. You're 29, finishing the 27th hour of a shift you technically weren't scheduled to work. The hospital is understaffed, the trauma ward overflowing, and the generator kicks in 10 seconds after the lights die. 10 seconds of darkness is enough for everyone in the room to imagine worst-case scenarios. A ventilator stopping, a monitor going silent, someone dying in the dark. The lights flicker back on, you tie the final knot. Next, you say, you believe this is the life you will live forever. Endless patience, endless triage, endless decisions about who gets attention now and who can wait 10 minutes longer. It is exhausting, but it is honest work. There are rules. There are charts. There is liability insurance and administrators who complain about overtime. Then 4 men walk into the trauma bay carrying a fifth. They don't check in. They don't ask permission. They don't even look at the nurses. The man they're carrying is bleeding through 3 layers of fabric. Bullet wounds. At least 2. Maybe 3. His breathing is shallow and wet. You immediately understand 2 things. First, if you follow the hospital protocol, security will be called, then the police. Second, if you do that, someone in this room will die before the police arrive. One of the men places a pistol on the metal instrument tray. Not pointed at you, just there. Doctor, he says calmly. He needs surgery. You look at the patient. Entry wound below the clavicle. Another in the abdomen. Possibly a third in the flank. Blood loss is severe. If you move him upstairs, he might not make the elevator ride. If you call for a trauma surgeon, it will take 15 minutes. You are not a trauma surgeon, but you have assisted in enough procedures to know the steps. You make a calculation that takes less than 2 seconds. You say to the nurse, prep the oar. Now, no one mentions the gun. No one mentions the police. You operate for 4 hours. You clamp an artery you've only seen in textbooks. You suction blood faster than the machine can keep up. Twice you think the man is gone. Twice you keep going, because stopping guarantees he dies. At 6:18 a.m., the bleeding stops. At 6:27 a.m., the man's blood pressure stabilizes. At 6:41 a.m., you close the final incision. The man with the pistol nods once, "Thank you, doctor." They leave without paperwork. The patient leaves with them. Hospital administration asks questions later. You answer carefully. No one presses too hard. Hospitals lose patients all the time. A week later, someone knocks on your apartment door. He's wearing a suit. Not expensive enough to be corporate. Not cheap enough to be careless. He greets you by name. He tells you your sister's address, your mother's phone number, your student loan balance. Then he places a small envelope on your table. Inside is a number written on a card. You assume it's money. It isn't that it's an address. You start Monday, he says. You laughed, he doesn't. There will be armed guards, he continues. You'll have better equipment than your hospital, and patients who cannot go anywhere else. What if I say no? He studies you the way surgeons study CT scans. Then he shrugs slightly. Then someone else operates, he says. And if they're worse than you, patients die. He pauses. And if they die, sometimes their friends become emotional. He stands to leave. You did good work last week, he says. We prefer competence. He walks out. You don't call the police. Monday morning, you drive to the address. The gate opens automatically. That is the moment you become a black market surgeon. The clinic is in a converted warehouse. No signage. No registration. No legal existence. The operating room is cleaner than the one at the hospital. The equipment is newer. Someone invested millions into this place. You meet your first patient 15 minutes after arriving. He is handcuffed to the gurney. Not by police, but by the men who brought him. He has 2 bullet wounds and a knife wound. He is conscious enough to say one thing before the anesthesia takes him. Don't let them kill me. You don't ask who them is, you operate. By the end of the week, you understand the rules. Rule 1, you don't ask what happened. Rule 2, you don't record names. Rule 3, survival is the only acceptable outcome. Word spreads quickly in worlds where hospitals are dangerous places to visit. Your patients arrive with gunshots, stab wounds, blunt trauma, burns, infections from amateur field surgery, shattered bones from interrogations that went too far. Cartel couriers, gang lieutenants, kidnappers. Occasionally someone who looks like an accountant but travels with forearmed guards. Your job is not justice. Your job is damage control. At first, the moral conflict nearly breaks you. You know, some of these men have killed people. You see it in their scars, in the way their escorts watch them, in the way they talk when they're half-conscious. Once, a man wakes during recovery and laughs weakly. "You saved my life," he says. Then he tells his friends they can finish the job tomorrow. You consider walking out that night. But then another patient arrives. 17 years old. Gunshot wound to the spine. He isn't a criminal. He's a courier's younger brother who was in the wrong car at the wrong time. If you weren't here, someone less skilled would try to remove the bullet. If they fail, he dies. You operate that he survives. That's when your internal logic shifts. You stop thinking in terms of guilt. You start thinking in terms of capability. If you leave, worse surgeons take your place. You become very, very good at your job. Within 2 years, your complication rate is lower than most licensed trauma centers. You innovate techniques because you have no bureaucratic restrictions. You perform surgeries that hospitals refuse because insurance companies won't cover them. You treat patients who would be arrested the moment they walked into an ER. Your reputation spreads across 3 countries. You also learn the real danger of your profession isn't surgery. It's loyalty. A gang leader once asks if you can make a bullet wound look like an accident. You say no. He asks again. You explain calmly that surgical records don't exist here, but anatomy still does, that he studies you. Then he laughs and drops the subject. You learn something critical that day. Your protection is not morality, that it's credibility. If criminals trust that you only practice medicine and nothing else, you remain valuable. Valuable people are harder to eliminate. You keep strict boundaries. You refuse torture. You refuse to keep patients alive for interrogation. You refuse to alter bodies to hide murders. You operate. You stabilize. You discharge, nothing more. The system grows around you. Within 5 years, the warehouse becomes a network. 3 clinics point 12 surgeons, rotating anesthesiologists. An underground supply chain for medical equipment that bypasses regulatory agencies entirely. You don't run the business, but you design the protocols, blood supply systems, emergency triage algorithms, mobile surgical kits for field stabilization. You even develop a system for anonymous patient codes so surgeons can track complications without knowing identities. Ironically, your black market operation becomes more organized than many legal hospitals. Then, the first raid happens. It's not the police, that it's a rival group. They don't want medical care. They want your patients dead. You're halfway through a thoracic repair when the first shots hit the outer wall. The anesthesiologist looks at you. What do we do? You clamp the artery. Continue. Gunfire echoes through the building. Security responds. You keep operating. Because once the chest is open, stopping guarantees death. 2 hours later, the patient survives. 3 security guards do not. After that night, you understand another truth. Your clinic is not neutral territory. It is a resource. Resources create conflict. You spend the next 3 years negotiating a fragile rule across the criminal ecosystem. The clinic is off limits, no weapons inside, no retaliation. Patients leave alive if possible, everyone agrees. Not out of morality, out of self-interest. Everyone eventually needs a surgeon. The rule holds, mostly. You age faster than you expected. You've performed over 2,000 operations that technically never happened.